So you have to do a major clinical assessment for delirium because sometimes it can be confused with dementia. You know, dementia is a progressive disease, it's chronic, and they do forget things as well, and they change, you know, the person's behavior. So you can get confused with the two. But the key thing to know about delirium and then dementia, and don't forget Alzheimer's is a type of dementia, is that with delirium, it's acute, it's chronic, right? It happens like this, and there is a cause. With dementia, like Alzheimer's, this happens over time. It's progressive, and it's irreversible. And like we already know here with delirium, if we can find the cause, we can reverse the problem. All right. Now, it helps to know an individual's, they say here, it helps to know an individual's uh, usual mental status, like how they normally behave, and their changes noted long term. So if you see these changes long term, then you might want to think, okay, maybe that's dementia. But if the changes occur like abruptly out of nowhere, then you'll say, oh, maybe this is more like delirium, you know, like it happened out of nowhere. It's abrupt, it's an abrupt onset. So now, what causes delirium? So there are causes, right? Secondary causes will include physical illness, surgery, medication, alcohol toxicity, dehydration, not enough fluids, fecal impaction, that's constipation, malnutrition, you're not getting the right amount of nutrients, you might have an infection, you might have a trauma to the head, lack of environmental cues. Remember back to the sensory overload and sensory deprivation that we was talking about in our other series. And those things right there can cause dementia. I mean, see, don't mess up. Those things right there, if it can cause it, you know it's delirium. Also UTIs as well, because that's also an infection, right? A UTI infection. So older adults are particularly vulnerable to acute confusion because of their decreased biologic reverse and the large number of medications they may take. Basically, older adults are vulnerable for acute confusion because they do take a lot of medications. You know what I'm saying? So, like I said, medications can cause delirium, so they are at risk for getting that problem, right? So we have to recognize the symptoms of delirium, and we have to report these changes immediately. Didn't I say before that if it goes unrecognized, then they can have sudden death? All right, so with that being said, there's a screening tool that's used to see if they may have delirium, which is called the confusion assessment method. And that's a screening tool. So you can check that out if you want to. But because of the acute and unexpected onset of symptoms and the unknown underlying cause, delirium is a medical emergency. When you hear something like if it's undiagnosed, it can progress to brain damage and death. Of course, that must be a medical emergency. So we have to take this thing extremely serious. It's not a joke. All right. Like I said, if it's not treated, it can cause permanent, irreversible brain damage, and death may follow. So the most effective approach to dealing with delirium is basically you're going to want to prevent it. We don't want it to occur. So with that being said, we need to monitor our daily activities with our patients that are older and make sure they're not experiencing sensory overload. They're not experiencing sensory deprivation. Their medications are not having terrible interactions. The medications don't cause depression. And then, because like I said, what causes it? I said it causes physical illness, infection, dehydration, fecal impaction, malnutrition. What else? Surgery. When you're going through surgery, what are you going through? Pain. Pain. Pain can cause it. Pain can cause delirium. It can affect how the brain is thinking. All right? So, how do we prevent it then? Well, we're going to go ahead and reorient our patient if needed, like to time, place, and where they are. Ensure early mobilization. So it means we're going to get them moving. We're going to get them moving because sensory deprivation. If you're not moving, you're deprived of your senses, right? Of the movement part. So you need that. You're going to control the pain. We're going to give them pain meds if they're going through pain. We're going to minimize the use of psychotic drugs. If they're having a hard time sleeping, we're going to help with that. Give them some drugs that help with sleep, or play some good, music that helps them sleep, enhancing communication methods. So like, let's say, all right, they can't hear, they need hearing aids and it's not working. We're going to make sure that it's working, because if the hearing aid isn't working, what's happening? Sensory deprivation. They're not getting their senses that they need, as well as glasses. If they can't see well, then they're not able to read and get that type of sense. You know what I'm saying? So like I said, these senses are very important, and we need to make sure that they're getting sensory stasis, the right amount of senses needed for their particular body. All right? So we're going to maintain their oxygen levels, their fluid and electrolyte balance, and we're going to try to prevent surgical complications. And this all can be done with good nursing care. Let's say we couldn't prevent it, right? We couldn't prevent delirium. We tried to do all we could, but it still occurred. So what's the next step? What's the next action that must be taken? Well, what we need to do is provide treatment. All right? Treatment is vital in this situation. So, okay, it's happened. We tried our best to prevent delirium from occurring, but it has occurred and we've noticed the signs and symptoms. So now we need to go ahead and provide treatment. How do you provide treatment? Well, we got to find the underlying cause. So obviously we're going to run a whole bunch of tests to find out what's going on and see what can be done. People that do have delirium are not in their right state of mind, right? So they have a disturbance of their consciousness, right? So therefore, they're at increased risk for falls, right? And therefore, patient safety is compromised. So we need to make sure that they're safe. And the behavioral problem also may occur. They might be fidgety. Like I said, they're either really low, either really high when it comes to their activity. So we need to make sure that we can control the environment for those type of behaviors, right? Of course, medical interactions and toxicity are often implicated. The nurse should alert the prescriber about any non-essential medications that could be discontinued. So if they don't have to be taking certain drugs, let's stop it for right now, because at this moment we're trying to find out the cause of the delirium, and if they don't have to have a drug, we need to just stop to find out what could be causing this issue. Like I said, we know that nutrition and fluid intake can cause delirium. So we're going to make sure they have enough nutrition in their body, and we're going to give them enough fluid intake during this time. We're going to supervise that and monitor that. Then the environment, like I said, sensory overload and sensory deprivation. We're going to make sure that they're at their optimal sensory stasis. So make sure it's calm and quiet and soothing and colorful. They need colors, things that will allow them to feel at home. Even pictures of home, like pictures, different ornaments they like. Bring it to the hospital or nursing home to make them feel comfortable, to make them feel at ease, right? To increase function and comfort, we can provide familiar environmental cues. And then we need to encourage the family members to come over. We need social interaction. Every human being needs social interaction. I know you've watched movies, guys, where you see the person that's stuck in a hole for days or months or weeks, and they just start seeing things. They start seeing people. They start talking to themselves. We say they're going crazy. That's the form of delirium. I mean, the brain is now activating the reticular activating system in your brain and keeping it moving, because at the end of the day, to live, that has to function. For living, it's vital to get the brain active. And if you don't have anything stimulating it, then the brain is going to do it for you, right? So we're going to make sure that we have family members come along, touching them, feeling like they're loved and cared for, because that's something that every human being yearns for, all right? So with dealing with that, we're going to figure out the underlying problem and take care of it. So what we'll do is once we've done that, we're going to do an ongoing mental status assessment using prior mental cognitive status as a baseline. So like I said, we did those tests before, right? So we're going to keep on looking at the results to see if it has improved. And hopefully it does improve as the time progresses. If the problem is treated, then the baseline will return in several days.